Carilion Clinic. I'll serve as your moderator today. We're going to learn about the differences between hospital-based and home-based care, how you can benefit from receiving care at home, and how you can qualify and pay for that home-based care, because a lot of people have questions about things that they aren't expecting or that they haven't planned for. So we're here to answer a lot of those questions for you today. So we'll start with our presentation with Dr. Unwin and Lisa, and then we'll follow with some questions and answers. So we have gotten the hang of the Teams function now. You can enter your questions in the chat box during our presentation, and then we'll take a look at them at the end. Just put a message there, enter your question, we'll address them at the end. I'm going to show you guys just a quick little example. Well, it won't take my message there. My computer's slow today. So I just put a little test message in there, so it's as easy as typing your message in, and then we'll take a look at them at the end. And in the meantime, we're going to go ahead and get started. Dr. Unwin, take it away.
Thank you very much. Lisa and I are excited to share this time with you today to tell you about our passion and love of home health care and the things that home health care can do for patients and their families. We have no disclosures, and let me get my clicker working here. We have no disclosures for you today. Our objectives today really kind of boil down to that first point, to discuss what to expect from home care and how to set realistic goals so our patients and our families can make informed decisions about their care. We'll talk about some options in home-based care. We're going to spend maybe some significant time about the transitions in care that occur when we go from our homes where we want to be to hospital environments back to home. And then we'll talk to you about some new and exciting things that are evolving in the future for home care. Our acknowledgements begin with you, our patients, our caregivers, our healthcare teams, Carilion Clinic, and the terrific folks at marketing and communications that helped put all this together. I'm going to turn this over to Lisa to begin our presentation.
Thank you, Dr. Unwin. As he has already said, it's good to be with you all today. You know, when we think about home care, we go back in history to where it all began. Lillian Wald was the first public visiting nurse in the United States in 1893. She founded the Visiting Nurse Service of New York, and she said nursing is love in action. And there is no finer manifestation of it than the care of the poor and disabled in their own homes.
That is something that is also embraced by the profession of medicine, where initially when medicine was provided to our patients and families, it was in the patient's home. And this tradition continues in different ways now. And again, we'll share some new exciting things that may bring the provider presence more into the home in the future. But we wanted to begin this talk with talking maybe about something uncomfortable, and that's talking about decline that leads to death in late life. The vast majority of healthcare delivered in the home through home health or hospice are for patients that are in late life. And if we begin with the end in mind, patients die typically in 4 different ways. There's the decline that, or the lack of decline in some ways, that occurs with sudden death, where a person is functioning normally and then suddenly declines and dies. And that only happens in about 7% of older Americans. That means that about 93% of Americans have or will experience the need for caregiving at some point in their lives if they are suffering from a terminal illness, such as from cancer, or suffering from chronic diseases such as heart failure or chronic obstructive pulmonary disease or liver disease, or suffering from frailty. Frailty being that phenomenon, especially in older adults, where a person has multiple medical problems going on that limit their ability to function and meet their day-to-day needs. And those people need assistance, and that's where caregiving and home health care come into play. For me, my personal definition of what is geriatrics is that it is the medical and social care of the older adult. And for me, geriatrics is that time where I hopefully am helping my patients by carrying their burdens and lessening their burdens as they try to promote their strength and preserve their function. But as we all know or have experienced, that there comes a time when that ability to promote and preserve function just doesn't work anymore. And we then need to focus on palliating symptoms and supporting families and patients as the person declines. And that support I think of as a parachute, creating supports for the patient and family so that that individual has a soft landing at the close of life. How do we do that? Well, conceptually, again, my opinion would be that if we can organize our medical treatments around what matters most to patients, that promote their function, that promote their mentation, their cognitive, emotional, social, and spiritual functioning. If we can do those things for patients and families, ideally within the home, we will be successful as doctors and healthcare systems. And this philosophy of care is embraced by what is now called the age-friendly health system, as proposed by the Institute of Healthcare Improvement. With that care requires a recognition that we can't deliver all care in the home at all times, and that when we do get sick, we have to go to the doctor's office or the emergency department, or we're going and staying in the hospital, or maybe a short stay in rehab. When we are hospitalized, often we are experiencing multiple transitions between home, emergency department, hospital, skilled nursing facility, back to the hospital. And unfortunately, many times we're readmitted after a hospital stay. And during these times of transition, we're vulnerable and we need assistance to care for ourselves. And it's also in these times of transition that medical errors commonly occur because of all the complex changes that are occurring. These errors can result in readmissions, increased length of stay, frank complications, and these readmissions are often complicated by the loss of the ability of the person to function for themselves, maybe because of confusion or dehydration or malnutrition or the inability to move. And let's face it, as we get sick, our healthcare needs get more and more complex. Unfortunately, these individuals are the people that are at most risk for developing this, what we call post-hospitalization syndrome. And we have to be very, very careful and be very attuned to the needs of the very old that may be living alone, who may not be able to care for themselves because of their financial status, their impaired reasoning, or simply the complexity of their healthcare. Lisa?
As Dr. Unwin mentioned, as patients transition from one level of care to another level of care, that's when things can go horribly wrong. And that's when a very assertive caregiver can be a fundamental part of the plan to care for that patient safely. One of the things we want caregivers to ask for and assert themselves into is the discharge plan. Prior to our loved one changing their level of care, we want to know exactly what's happened during that prior period of care. We want to know what's coming up in the next leg of the journey. We as caregivers need to assert ourselves into conversations about medications. We need to understand exactly what medications our loved ones are to go home on. Oftentimes, medication errors errors represent the #1 cause for readmissions. If there are changes in treatment plans, our caregivers need to understand what they are and how to administer those. We want to know when the follow-up appointments are to occur and who we are to call for changes or questions. We also want to know about advance directives. Dr. Unwin talked a lot earlier about the fact that if we can understand our loved one's wishes and plan the care around those issues and interests, we can ensure that soft landing that he described previously.
In an idealized way, what we in some ways all hope for is that if we get sick, we go home and we don't come back unless there's some new or different problem that occurs. And ideally, that would be the way all healthcare is delivered, where you have your high intensity, high acuity care met, and then it de-escalates over time, and that we would not have to go back and revisit the same old problem again and again and again. And in an idealized world, we would progress slowly and gently through life, where we would have our needs being met in home, and then in an ideal world, after our lives are well lived, we enter into hospice care for late life care. But it's very complex, and the chronicity of care and the needs of the patient and family result in a lot of going back and needing additional care through nursing homes or home health care, so that this journey through life can occur. So to get to the question then, what to expect from home care really boils down to really 3 answers that are very unfortunately vague. It depends on the needs of the patient in terms of their healthcare needs, their cognition, their home environment, their social supports. It depends on the abilities of the family and caregivers to provide care for the patient. Because, for example, if you are the caregiver for your spouse and suddenly your back pain acts up, or you have a recurrence of your cancer, then meeting the healthcare needs of your loved one changes with you as the caregiver. And these environmental factors that you've heard me hint at in terms of the home or financial issues or all the things that create this bubble of people, places, and things that support us, those things are crucial in how we receive the care that we deserve. Lisa?
Oftentimes, the needs of our patients often are grounded and rooted in limited mobility. So when you look at the age group of 60 to 69 years of age, 6.5% of those individuals have some type of functional impairment that limits their mobility. And oftentimes, it's not the disease itself that challenges us in terms of our functional abilities, but it is the side effects of those illnesses that limit our ability to move around safely. And in fact, when we talk about care in the home, one of the major areas that we're interested in promoting and maintaining is those activities of daily living, the ability to bathe ourselves, dress, walk safely within our home environment, prepare our meals, and even control bowel and bladder. But the reality is that about 1/3 of our older adults will spend at least the 3 months of their lives in a nursing facility prior to dying. 1/3 of older adults will rely on paid caregiving. And as Dr. Unwin mentioned earlier, oftentimes our families and our patients don't have the financial supports needed to provide that in-home caregiving. And then, of course, there are other limitations to our functional activities of daily living, and that may be our impaired vision or our impaired hearing. All of those contribute to the complexities that often exist in designing a plan of care that can be delivered in the home, but all need to be respected as part of the development of that plan of care.
Lisa and I have been involved with home care throughout our careers. And we recognize that home is not just a place, but home is people. And home is a spirit, and there's a lot of emotion attached to home. But at a very real level, also home is a financial resource that often gets called upon to be used to care for an individual that has increasing healthcare needs. Wealth in America often is determined by home ownership, and you can see some of the data there in terms of how much of our money, our net wealth as individuals, is tied into our homes. And that wealth often is what is needed. That money is what is needed to provide out-of-pocket expenses to support healthcare in late life. And this home, this picture that I'm showing you here, also presents that in part of that environmental challenge that I'm talking about. Outwardly, this is a lovely home on the outside, but for an individual that faces significant physical disablements, by simply parking that car in that garage, that person may have to go up 4 flights of stairs to get to their bedroom. And those flights of stairs could be very burdensome to manage if a person is suffering from a significant stroke or severe arthritis. Lisa and I have also known and discovered that older adults and their families are very, very smart people. That, to quote F. Scott Fitzgerald, they are facing very challenging circumstances that often at times feel hopeless, but people are very determined to make that situation otherwise. And that's where assistance by home health, doctors and healthcare systems are there to try to help people through those difficult times. So we're going to talk a little bit about the nuances of getting care in the home next. Lisa?
Let's talk first about skilled home health services. So that is a service that can be delivered to patients in their home environment as long as that is not in a nursing facility. So home health services can be provided in a private home or an assisted living facility. To qualify for home health services, patients need to meet the Homebound criteria established by definition by Medicare, and we're going to talk about that in more detail in a moment. A patient also, to qualify for home health services, must need the skills of a physical therapist, a speech therapist or speech language pathologist, or a nurse. And once they qualify for those services, they tend to receive those services on an intermittent basis, maybe 2 to 3 times a week for a limited period of time. There's some confusion about the fact that a hospital stay is not required for a patient to receive services under a skilled home health benefit in their home environment. Patients can be referred to us directly from their primary care provider, and about 35% of the patients that we care for at Carilion Clinic Home Care originate from their provider or their doctor's office visit. A physician does have to see a patient to establish that medical necessity, and that visit has to occur either 90 days before or 30 days after home health care is officially started in the home environment. Let's talk a little bit more about what it means to be homebound, because this oftentimes confuses patients and families. For Medicare and Medicare Advantage plans, a patient is considered homebound if he or she needs the assistance of another person or equipment to leave the home, or if the doctor believes that leaving the home may actually worsen the patient's condition. In addition to that, it has to be difficult for a person to leave the home. However, there's some confusion around the fact that if a patient is homebound, they can never leave the home, and that's not true. Medicare says that patients can leave their home to receive services that cannot otherwise be delivered in the home, for example, dialysis or chemotherapy, or a patient can attend church services or run to the pharmacy to pick up medications on occasion. And again, as I already mentioned, the physician, a provider, has to certify the need for that service. Now, once the patient qualifies for home health services, if we move to the next slide, then that service is delivered for a defined period of time. Generally speaking, the service lasts 30 to 60 days, on average in the 40s for home health at Carilion Clinic. Once that person qualifies for home health services, I mentioned those 3 disciplines that we talked about: physical therapy, speech therapy, and nursing. Once the patient qualifies for one or more of those 3 disciplines, he or she can receive occupational therapy, the services of a home health aide, or a social worker. Again, there's some confusion around aid services sometimes. So the aid service is provided on an intermittent basis and not for extended periods of time. For instance, the aide can't sit with a patient for 4 to 8 hours. Generally speaking, those services are focused on bathing and assistance with activities of daily living, and they are time limited. Again, the service can be provided as long as the doctor certifies that the service is medically indicated for a particular patient, but on average, that service lasts anywhere from 30 to 60 days. Now, when we talk about those definitions, we tend to talk about Medicare and Medicaid recipients, as I mentioned. If a patient has another payer, not Medicare and not Medicaid, commercial payers, generally speaking, follow the Medicare rules. However, those rules are trumped by their group or individual plans. So it's important that a potential home health beneficiary look at those private plans in advance of receiving that services to really understand the financial obligation that may be associated as defined by the insurance plan.
One of the things that I'm very proud of being part of Carilion Clinic and the home health program here is the Carilion Home Health Dementia Care Services Program. Dementia is a very common phenomenon that is experienced by about 1 out of 3 older adults. And when or if you've experienced caring for someone who has dementia, you realize that often these individuals create and you get placed in a position where that person is in many ways homebound. And what Carilion Clinic has done is created specially trained nurses, physical therapists, occupational therapists, speech therapists, and aides that have additional knowledge and skills in assisting patients who are experiencing dementia and the caregivers that are supporting them to how to improve function in the home while simultaneously wrestling with the needs posed by a person having dementia. And this creates an emphasis area on advanced care planning and addressing patient capacity, and then working with the caregivers and family on mobilizing financial resources and creating plans that assist the caregiver in caring for that patient who is experiencing dementia. This service provides assistance to the caregivers in addition to the patient. Lisa?
You know, Dr. Unwin mentioned early on the fact that sometimes it's difficult for us to talk about dying. It becomes uncomfortable for our loved ones sometimes to hear conversations we have about dying. But the reality is we were all brought into this world through the process of birth, and we will all leave this world through the process of death. And our goal as a healthcare team is to ensure that that transition is respectful, dignified, and peaceful. So there are times inherently that our conditions worsen, and we need the expert team of a hospice group to help us with that pain and symptom management. So in order to qualify for hospice, a doctor has to certify that the condition that we have or our loved one has, that if it were to run its normal course, may result in our death within 6 months. We as a patient under hospice care have to also philosophically understand and be at a point at which we accept the fact that comfort is more important to us at that moment in time as opposed to cure. There are specific disease criteria that Medicare defines one must review to be eligible for hospices. And we've been doing a lot of training for physician groups in the communities that we serve to help them understand that criteria, and the doctor will determine that. We mentioned the importance of therapies in home health. Therapies are also important for and can be provided in hospice, but the goal of the therapy in a hospice plan of care is to help maintain safety in the home, not necessarily aimed toward rehabilitation. Once a person qualifies for hospice, those services can be delivered in the home environment, the residence of the patient. Those services can be delivered in an assisted living facility, and those services can be delivered in a nursing facility. In most cases, patients in a nursing facility are not receiving skilled rehabilitative care in concert with hospice care. Medicare pays 100% for hospice services. They also pay for home health services with no copays or out-of-pocket expenses to the patient. There are specific Medicare Advantage plans that may require a copayment. There are specific commercial provisions in any individual plan that one must also review. And Medicare does not typically pay that room and board expense if we're caring for a patient that is living in a nursing facility. I mentioned previously the qualifying criteria for hospice, but I want to reinforce that because oftentimes that leads to confusion among families. Hospice is not time limited, meaning that an individual must receive hospice for 6 months or less. Instead, the definition is that if the illness were to run its normal course, one might expect passing within 6 months. However, we provide services to patients far in exceeding of 6 months, as long as they continue to qualify for that service, and that's typically determined by the hospice physician. Once a patient qualifies for hospice, then they receive the services of a multidisciplinary team. And I mentioned the fact that these are teams of experts, and I stand by that and I reinforce that. These are nurses and physicians who are especially trained in caring for a patient exhibiting specific symptoms. The team is led by the hospice physician, and here at Carilion Clinic Hospice, we are blessed to have nurse practitioners as part of that team as well. The patient will receive nursing services, social work services, aid services to help with personal care. A service often demanded by our families is volunteer services to provide some respite for the caregiver, some time that the caregiver can get away to make a visit to the bank or pick up a medication or just have lunch with a friend, for instance. We recognize the importance of grieving even before death and to extend to the family after death. So we provide bereavement support to our families for 13 months after the passing of a loved one. We are all spiritual beings. Our beliefs may be different, but at the core of our being, that we are a spiritual body. And so we have spiritual counselors on staff that can help meet a patient wherever they are in their spiritual journey, honor that, support and respect that. At Carilion Clinic Hospice, we're blessed also to have board-certified music therapists and massage therapists to provide comfort care that makes the biggest difference oftentimes in the physical care that our other team members are providing to our patients. And then there are certainly other services that are available and vary by hospice provider in the community. What you might expect from a hospice team are frequent visits by members of that interdisciplinary team that I just described. Again, oftentimes we hear from our patients and families, well, we thought that hospice was a 24-hour service. And the reality is it can be under specific provisions, but that provision is that the patient qualifies for hospital level of care and can be in a facility that is certified and accredited to provide that level of care. So hospice care delivered in a residence or the patient's environment is not continuous care. It's intermittent, interdisciplinary care by that team of professionals that I just mentioned. Oftentimes, however, patients come on hospice service and their goals of care may change. They may determine that they are not quite ready to stop that chemotherapy or that radiation therapy, and they can actually withdraw themselves from hospice and enter another level of care. But the good news is that 15 to 20% of the patients that ultimately enroll in hospice get better once their symptoms are managed and they actually graduate from services when they no longer qualify. Patients oftentimes just need assistance with activities of daily living, those vital functions of bathing, meal preparation, maybe assistance with laundry and that type of thing. Those services can be provided to anyone by a home health aide. But in 99% of the cases that we see, those services are provided on a private pay basis. That is not something that outside of a medical need, insurance plans pay for. I have seen some patients that had long-term care plans that helped offset the expense of a private care aide, but generally speaking, those are not covered by insurance unless a patient has Medicaid and has been evaluated by a Medicaid designated individual and have established needs in the home. When receiving these services, the service is focused on personal care and routine home activities. And to Dr. Unwin's point earlier on, these services over a period of time can become financially burdensome. And the reality is that today, home health aides are in short supply, and locating an agency or an aide personally that can provide these services for a long term is sometimes troublesome.
So one of the resources available to us in these troubled times and before these troubled times were adult day centers. And think of this as a home-like environment where patients can be dropped off by family members or picked up by the adult day center, brought to the adult day center for a home-like environment that would include recreation, food services, and a variety of other services that are potentially provided in that day center environment. Day centers receive payment through either private pay or sometimes with Medicaid. And this is for people that have a home and they have a caregiver. And the adult day centers are for people that can generally provide for their own mobility and transfer needs. With this, these services are typically provided Monday through Friday. And if there are additional services that are needed, such as bathing, additional costs may apply. But when you look at a cost per day of $100 a day or less, this becomes a very viable option for some families that are maybe saying to themselves, Dad would love the support and friendship and meeting other people, and that will allow me to go to work while Dad is receiving care in the adult day center, and then I can pick Dad up and we can go back home and be together at night. It's a wonderful resource in our community, and adult day centers are scattered throughout Southwest Virginia. Another resource for families are what are called PACE programs, or programs for all-inclusive care of the elderly. And a way of thinking about this is that these are adult day centers that, in a way, have a clinic there in the facility with physical therapists, occupational therapists, and providers, such as nurse practitioners, physician assistants, or physicians to meet the medical care needs of the older adults in those programs. PACE programs are designed for patients age 55 and older, and typically directed for patients that are called dual eligible. These are patients that receive both Medicare and Medicaid. PACE programs are typically available Monday through Friday, 5 days a week. And again, this is kind of a managed care program that provides a really terrific bundle of services to include things such as medication management, on-site or in-home therapy, transportation, dental, and podiatry services. And here's a brief list of the PACE programs here in Roanoke and then throughout Southwest. Spend a moment talking about independent living facilities and assisted living facilities. Independent living facilities where are basically senior centers, typically, where the patient is able to manage themselves independently, or they may be paying for services to come into their home. This is all private pay. Typically, there's no 24/7 nursing, and any kind of additional services, additional meals will be at additional cost as part of the contract with the independent living facility. Typically, you continue with your own private physician. But independent living facilities and assisted living facilities may exclude patients with dementia because of the patient with dementia may not be able to be fully independent because of their memory or functional deficits. Independent living facility costs vary widely, but it's important to note that private duty services and things like hospice and home health care can and do go into independent living facilities to provide that support. Assisted living facilities are where patients may have deficits or troubles with their self-care needs, and cognitive impairment may be present. Again, this is private pay. And again, Medicare and Medicaid do not pay for that bed and breakfast provided by the assisted living facility. And the scope of services provided by that assisted living facility vary from place to place and vary according to cost. It is really important to understand the exclusions that you would face as a patient or a family member, because if a patient is no longer meeting criteria to stay in the facility, an alternative living arrangement would need to be made. Lastly, nursing facilities. These are for people that are having difficulty with their self-care needs. Medicaid will pay for nursing home related facilities for qualified individuals. Long-term care insurance will also typically pay for long-term care. A minority of Americans pay out of pocket for long-term care expenses, and this is where our loved one requires 24/7 nursing. And there are structured policies and procedures in place to monitor the patient's vital signs, weight, nutritional intake, behaviors, etc. The role of the physician in the care of that patient varies based on the facility and the community. Some primary providers continue to see their patients when they enter into the nursing home. Other providers do not. Long-term care facilities cannot take care of patients who have uncontrolled aggressive behaviors, and sex offenders are not typically allowed in long-term care facilities. Facilities try to promote a least restrictive environment with no restraints of any kind, chemical or physical restraints within their facilities. One really good resource for all of us to be aware of is the resource through the Virginia Senior Navigator program at seniornavigator.org. And this is a one-stop shop where you can enter questions, information involving questions about caregiving, aging well, legal questions, housing options, community resources, transportation resources available in your community. seniornavigator.org. And Lisa, tell us about quality of care in your domain.
Certainly, we live in a society of well-informed individuals, and access to information is unlike it's ever been before. One of the things that we always recommend to our patients and families is that you research the providers in the area that you think you need before you execute a plan to have a provider come in your home. Some of that information can be found on Medicare.gov. You can go to Medicare.gov, query nursing home compare, home health compare, or hospice compare. You can enter your agency zip code that you're in need of, and you can compare those results to other organizations in the same area. That can be part of your plan in selecting a provider. You also may want to have conversation with the leader of that organization as well to understand the culture and the expectations as another opportunity to vet providers before allowing them in your home.
We're now going to transition over to new and exciting things that are happening in home health care. And for those of us of a certain age, we probably remember the Simon and Garfunkel song of Homeward Bound. And that's really where people want to be, both in our personal and spiritual, and our comfort is at home. And COVID in many ways has helped trigger new ways of thinking and aligning healthcare with care in the home. So there are currently millions of Americans that are receiving informal and informal healthcare services in the home. But if you look to the right of the slide, you'll see that really not many people are getting home-based primary care and hospital at home. But with COVID, we're discovering that maybe that is a place that healthcare systems should direct more effort and energy and resources to, where we are providing high acuity, acute care with provider involvement, but providing that in the home. And we're doing that in a lot of different ways with telemedicine, and many of us have used telemedicine, or urgent care at home, or using specially trained paramedics to visit you in the home in a crisis. Lots of different new and exciting ideas are being explored, and Carilion Clinic is part of that exploration. Important to all of us, though, are addressing the special needs of the homebound individual. And roughly about 6% of Americans are truly homebound, where they cannot get out of the home without exceptional support and service. And unfortunately, people who are homebound rarely get primary care. And what that means is that the patient is suffering there at home, and then when it becomes too much, they come to the hospital, often very seriously ill. People who are homebound typically face many different challenges. Often they are very sick with frequent hospitalizations. Often they're immobile or suffering from dementia, depression, generalized poor health. They are of limited financial means, often alone, and often with limited educational attainment that limits their ability to navigate this very complex system called healthcare. And if we were to look at this regionally, just looking at Roanoke City and County, taking a look at the data, roughly 1,600 patients in our community in Roanoke City and County are homebound. And in 2040, roughly 10,000 people will be suffering from dementia. And that's a lot. That's a lot being called upon our community to deal with. And so how are we going to do that? And well, doing it ideally would be in the home. And so one innovation actually led by the Veterans Administration is home-based primary care, where basically doctors, nurses, therapists, social workers, aides, food assistants, legal supports and services are coming to you and caring for you in the home. The outcome from the VA experience from home-based primary care is very, very favorable, with reduced emergency department visits, reduced hospitalizations, reduced use of long-term care, and reduced cost. Exciting times, I believe, are ahead as I think our nation is shifting towards providing more care in the home. And Lisa's going to tell us more about how that might be happening.
COVID has created a lot of challenges, but it's also provided us some gifts in the healthcare industry. And one of those gifts is remote medicine. As Dr. Unwin mentioned before, telemedicine skyrocketed. The use of telemedicine increased significantly in the height of the pandemic when we needed to socially isolate and keep patients with symptoms separated from others. There's technology that is at this time being deployed within Carilion Clinic to enable a patient in the home to have the equipment of a stethoscope, an otoscope, an ophthalmoscope, or things to look in the eyes and ears, and connect on the other end of the software system to a doctor or a nurse practitioner or a physician assistant. Telemedicine has enabled greater access to health care in the last 18 months than ever before. Certainly at Carilion Clinic, if we go to the next slide, Dr. Unwin, we provide remote telemonitoring as well. So when we have patients who have a chronic or complex serious illness that needs to have constant monitoring, so by that I mean we need to be taking a look at that patient's weight every day. We need to understand the fluctuations in the blood pressure that's occurring every day. We need to look at the oxygen levels that patient may be experiencing. That can all be accomplished through remote telemonitoring systems. That system enables the patient through wireless devices in the home to capture all of those readings, and also with an iPad respond to questions that are geared toward health coaching, so that we can understand a correlation between the patient's activity and the symptom that he or she may be demonstrating. Next, there are some somewhat high-tech but low-cost solutions to maintaining safety in a home environment. In our area in home health and hospice, we see more consistent and increased use of in-home cameras. Those systems can be highly complex and can monitor 24 hours a day through video, or they can be lower tech and enable a caregiver to periodically look in on their loved one through a mobile application on their cell phone. Again, we want to respect the privacy of our patients, and so oftentimes we ask our caregivers to obtain permission from patients before placing cameras in the home. But nonetheless, that can provide a sense of comfort to know that your loved one is safe in their home environment, in their kitchen or in their bedroom, not in the floor from a fall. Dr. Unwin mentioned our dementia care program, and one of the things that our dementia specialists work with patients and families on, especially when cognitive impairment results in wandering. A patient may have not an awareness that he or she is wandering away from the home. Our practitioners work with local law enforcement to use a technology called Project Lifesaver. It's a wearable technology that enables first responders to know where our patients might be if they've wandered away from the home. This, again, provides comfort not only to the patient because we can get services to them quickly if needed, but also to caregivers to ensure that they know the whereabouts of their loved one at any given time.
Just a few more slides until we get to questions, but I hope you also walk away with this internet resource, ageandplace.org, because caring for someone in the home involves that medical care in the home, but it also requires planning on our parts as families with respect to financial planning, legal planning, transportation, housing, and social and community support to support that patient and family in the home. It's not all about healthcare. It is about that medical and social community care and that advanced planning in preparation for that care provided in the home. And ageandplace.org is a great resource for that other planning to help support families in their homes. So this is our conclusion slide. Our goal, I think, as families and as a healthcare system is to promote the best possible safe function in patients' homes. And to do that, well, it depends. As we said earlier, it depends on the needs of the patient and meeting that patient for their goals of care and what matters for them. It supports family and caregivers to help the patient meet those goals, and it's trying to identify those environmental factors that may limit or enhance our ability to provide care to that patient. Also, knowing that there is emerging technology that is there for us to use if we have the resources to do so, to implement that care in our home. And beyond just the healthcare, think about those other things that we can do for financial and transportation planning, et cetera, that will complement our healthcare activities. We'll now take your questions. Here's our 1-800 number, 1-800-964-9300, and our website at carillionclinic.org/homecare.
Thank you, Dr. Unwin and Lisa, for that very informative presentation. Certainly heartfelt as well, and we know that you both are experts as you choose to live this life every day that many of us don't choose but still are forced to live. We do have one question about home therapy. Why does home therapy have to stop because my loved one really enjoys it?
I'll take that maybe from one perspective. Lisa, join in. I think the key thing that governs that is that the patient must be making progress to achieve those goals. And if the patient is not making progress or physically, cognitively is unable to progress to achieve a goal of walking or transfer in bed, et cetera, then the service is required by law to end. Lisa?
I'll only add to that, Dr. Unwin, to say that oftentimes patients get to a point at which they've achieved their goals that can be delivered in the home, and they may need equipment or services on an outpatient rehab basis. And they get graduated, if you will, to the next level of care in outpatient therapy. In addition to that, as Dr. Unwin articulated, there has to be progress toward goals. Oftentimes in the home, we see that the patient has met a plateau. And oftentimes the insurance coverage will not continue when that plateau has been hit or documented. So oftentimes it's within the purview of the insurance company as to when that therapy must end.
I think we have time for one more question because I know people may have to go right at that 1 o'clock time frame. I think this is an important one. As I'm thinking about having someone in my home, like a home health aide, what qualifications should I look for? What questions should I ask?
So I'll start that one by saying that, as we mentioned earlier, you want to make certain that you vet providers that are coming into your home. In Carilion Clinic Home Care, we strongly recommend that folks not allow individuals in their home that are not wearing a Carilion Clinic identification badge. Go to Medicare.gov, look at the medical and patient experience outcomes that are documented. Have conversations with the leaders of the home care organizations that you're vetting. Understand if the individuals that are coming into your home are bonded, if it's not through a skilled home health agency, for instance. We want to make certain we're protecting the integrity of the patient and their environment and finances and in every other way. Dr. Unwin, would you have other things to add?
I would only echo what Lisa said.
And let's go with one more then. Does Medicare pay for 24/7 in-home care?
Sadly, no. I could expand on that, but sadly, Medicare does not pay for that.
Are there any closing thoughts that you might have for our audience today? You've shared so much information, but just something that comes to mind that perhaps you wished you had touched on?
Lisa?
I think the experience that I have had within my own family is that home is the safest place for them. And moving folks out of their normal environment can often be well-intended, but have the opposite effect and can be disabling to a loved one. So we are here, we stand ready to wrap as many services as possible around patients to the extent that we can to enable them to stay in the safety of that environment.
And I would echo that, and I would add that when I was in the Army and my parents in their late life decline, it required us to plan. And the good thing in their experience was that we made extensive plans, my brother and I, in terms of their wills and power of attorney and living wills and alternative living arrangements and assistance in the home. And that served us very well when my brother and I were deployed in the Army. And I would strongly encourage the audience to really pursue that other planning, transportation, legal, financial, to assist the family in providing the care that is needed in late life.
I thank you both so much. I can personally say my family has benefited from the loving hearts and the expertise of Carilion Hospice, and I was so happy to be a small part of your wonderful presentation today. We hope that everyone has a safe and happy rest of their day, and we thank you for joining us today.
Thank you, Karen.